Welcome to the deep dive. We take complex stuff and, well, try to make it clear and hopefully pretty fascinating. So picture this. You go in for something routine, maybe getting a tooth pulled, simple, right? But what if that simple visit kicks off something much, much bigger, something really serious affecting your jawbone? Today, we're diving into a medical chapter looking at three pretty significant conditions: osteomyelitis, osteoradionecrosis, and bisphosphonate-related osteonecrosis of the jaws. Let's just call it BRONJ. It's easier. Our mission really is to unpack these for you, understand where they come from, how they show up, and why they're such tough challenges, both for the people experiencing them and for the surgeons trying to fix them.
Yeah, and it's really key to get this up front. They might seem like totally separate issues, but they all kind of share this devastating impact on the jawbone and how the body heals itself. We're going to look for the connections, the differences, and maybe some surprising things about how vulnerable, this part of our body can be.
Okay, so let's start with osteomyelitis. When we say that, it sounds serious. It's more than just a run-of-the-mill infection, right?
Oh, absolutely. It's not just like a little pocket of infection.
Yeah.
The sources define it as an inflammation deep inside the bone marrow. And the crucial part is its tendency to progress, to spread. It's not contained like a simple abscess or, a dry socket after an extraction. It actually involves the hard outer bone, the cortical plates, and the tissues around it.
Yeah.
It's this sort of self-perpetuating destructive thing.
And this used to be more common than less common, and now it's coming back.
Exactly. Before antibiotics, osteomyelitis of the jaw, especially the lower jaw, was, well, not rare at all. Antibiotics changed the game, made it much less frequent. But yeah, we are seeing a bit of a resurgence, maybe due to antimicrobial resistance, things like that. But what's really interesting is why the jaw, and specifically why the mandible, the lower jaw, is such a prime target.
Okay,
It comes down to anatomy, really. The mandible has this really dense outer bone, the cortical plates, and it doesn't have a great blood supply to begin with. Most of its blood comes through one main channel, the inferior alveolar neurovascular bundle. Compare that to your upper jaw, the maxilla. The maxilla's got much better blood flow from multiple sources, and the bone itself is spongier, less dense. So yeah, the mandible is just anatomically more susceptible.
that makes sense. So if the bone's already a bit vulnerable, what actually triggers the infection? What tips it over the edge?
It's usually not just one thing. It's often a combination. Systemically, anything that lowers your body's defenses is a big factor. So think like uncontrolled diabetes, autoimmune conditions, certain cancers, even malnutrition or AIDS. Then you have medications, steroids, chemo drugs, and as we'll discuss later, bisphosphonates can play a role. And locally, anything that messes with the blood supply directly, previous radiation therapy to the area, rare bone diseases like osteopetrosis, or just existing damage to the bone, all these can kind of set the stage.
Right, creating the opening. And you mentioned this vicious cycle. How does it actually develop inside the bone? Our sources talk about this cascade effect.
Yeah, it's a nasty cycle. It often kicks off with something seemingly small, like an infection from a tooth, or maybe trauma, an extraction, even a root canal sometimes, or a fracture. Bacteria get in. Your body reacts with inflammation, trying to fight it. But if the infection takes hold, pus starts to form. Now, inside the rigid bone, that pus builds up pressure. And here's the cruel twist. That pressure squeezes the tiny blood vessels, reducing blood flow even more.
Oh, wow. So the body's response actually makes it worse in this case.
Exactly. It sort of self-strangulates. Less blood flow means the infection can spread more easily through the marrow spaces, the bone tissue starts to die. And eventually that pus finds a way out, creating tunnels called fistulas that might drain into the mouth or sometimes right through the skin on your face. It's a destructive loop.
And the bacteria involved, they're mostly just the ones already hanging out in our mouths.
Pretty much. The mouth is, teeming with bacteria, hundreds of different types. We used to think Staph aureus was the main bad guy, but actually nowadays we see a lot of streptococci, and especially anaerobic bacteria, the ones that don't need oxygen, like bacteroides and peptostreptococci. Often it's a mix of different types working together, which is why treatment usually starts broad spectrum while waiting for specific culture results.
Okay, so given all that complexity, how do doctors actually classify this, and how do they spot it, especially if it's tricky early on?
Well, there are quite a few classification systems out there, which kind of tells you how complicated it is. But for practical purposes, it often boils down to acute versus chronic. Acute means it's been present for less than a month. Chronic is over a month. You also get specific types, like Gray's osteomyelitis, which has this characteristic sort of onion skin look on x-rays because of how the bone reacts, identifying it. Yeah, that's the challenge. Patients often describe this deep and boring pain, sometimes feeling way worse than you'd expect from looking at it. In acute cases, you might see swelling, redness, fever. In chronic cases, fever is less common, but you often get those fistulas, the draining tracts. And a really classic sign, if the infection is putting pressure on that main nerve in the lower jaw, is paresthesia numbness, or tingling in the lip or chin.
And you mentioned x-rays. Our sources say they might not show anything for weeks. That seems like a big diagnostic hurdle.
It really is. Standard X-rays, or even CT scans, often lag behind the actual disease process. You need something like 30 to 50% demineralization, actual bone loss, before it becomes visible. So someone could have raging acute osteomyelitis, and their initial X-ray might look totally normal. It takes time for the bone damage to show up. This is where MRI can be really useful. It's much better at picking up early changes in the bone marrow, like inflammation and loss of the normal fatty signal, sometimes weeks before you see changes on an X-ray.
Okay, so it's deep, it's destructive, hard to see early. What does treatment actually involve? It sounds like just taking antibiotics won't cut it for adults.
Almost never, no, except maybe in some rare cases in infants. For adults, it's pretty much always a two-pronged attack, medical and surgical. Medically, yes, aggressive antibiotics are key, ideally targeted based on cultures. But just as important is managing any underlying issues, like if the patient's diabetic, getting their blood sugar under tight control is absolutely critical for healing.
And then the surgery, the goal sounds pretty direct, to get rid of the bad bone so the good bone can take over.
That's the essence of it. You have to surgically remove the necrotic, the dead, poorly supplied bone, and encourage healthy blood flow. Procedures have names like sequestrectomy, taking out those chunks of dead bone, the sequestra, or saucerization, where they kind of reshape the bone to eliminate dead space and allow healing from the base up. Decortication involves removing the dense outer layer of bone to try and get blood supply from the overlying tissue, the periosteum, into the marrow. The absolute key surgically is to cut back until you reach healthy bleeding bone. Good bleeding bone is the term surgeons use.
But that sounds like it could weaken the jaw significantly.
It definitely can. That's why there's a risk of pathologic fracture, where the jaw breaks just from normal function. So often surgeons will use fixation plates internally or externally to stabilize the jaw during healing. There are also adjunctive things sometimes used, like antibiotic-impregnated beads placed directly into the surgical site, or hyperbaric oxygen therapy, HPO. HPO involves breathing pure oxygen under pressure to boost tissue oxygen levels. It's sometimes used for difficult refractory cases, but its routine use for osteomyelitis is still a bit controversial.
Okay, that's a lot on osteomyelitis. Now let's shift gears. Sometimes the treatment for one serious disease, like cancer, can cause its own bone problems. Let's talk about osteoradionecrosis, or ORN. And there was a big shift in thinking about ORN, wasn't there? It wasn't always understood the way it is now.
That's right. For a long time, people thought ORN was basically just an infection in bone that had been weakened by radiation, like radiation-induced osteomyelitis. But the real breakthrough came from Dr. Robert Marks. He proposed a fundamentally different view. He defined ORN not as an infection, but as a chronic non-healing wound.
Right.
The tissue becomes hypoxic, hypocellular, and hypovascular.
Okay, break that down. Hypoxic, hypocellular, hypovascular.
Yeah, basically. Low oxygen, hypoxic, fewer living cells, hypocellular, and a severely reduced blood supply, hypovascular. So the radiation permanently damages the bone's ability to repair itself. It's essentially starved tissue that can't heal properly. That's the core problem, not infection, though infection can certainly happen on top of it.
And that damage from radiation, it's permanent. It doesn't get better over time.
That's a crucial point. The effects are lifelong. The risks doesn't decrease years later. Now, the good news is modern radiation therapy is much more precise. Better targeting, shielding, careful planning, especially around teeth, so the incidence of ORN has gone down significantly compared to, say, decades ago. But it still happens. Usually it's triggered by some kind of trauma to the radiated area, most often a tooth extraction. But sometimes it can even occur spontaneously with no obvious trigger. Like osteomyelitis, it's more common in the mandible, especially when radiation doses exceed a certain threshold, maybe around 5,000 to 6,000 rads. Clinically, it can look very similar. Pain, exposed bone is a key feature, and on x-rays you might see that moth-eaten look, bone breakdown, sequestra.
So if the core problem is this permanent lack of healing capacity, how do you treat it?
Well, one of the mainstays, historically and still used, is that hyperbaric oxygen therapy, HPO, we mentioned. The idea is that flooding the tissues with oxygen under pressure can help overcome the hypoxia, maybe stimulate some new blood vessel growth, angiogenesis, and help fight off any secondary anaerobic bacteria. It's usually an intensive protocol, maybe 20 or 30 sessions or dives, before surgery, then the surgery itself to remove the dead bone, and then maybe 10 more dives afterward. It can be effective, but it's also costly, time-consuming, and not available everywhere.
But you mentioned earlier there's a more, maybe, definitive surgical approach now, something that brings in completely new, healthy tissue.
Exactly. Microvascular free tissue transfer, or free flaps. This has been a game changer for severe ORN. Surgeons can take bone, often from the fibula in the lower leg, along with its own artery and vein, and transplant it to the jaw. They meticulously reconnect those tiny blood vessels under a microscope to the blood vessels in the neck. So this new piece of bone arrives with its own independent, healthy blood supply. It completely bypasses the damaged, radiated tissue bed. It brings in healthy bone and soft tissue coverage. And a really big advantage: HBO therapy is generally not needed when you do a free flap reconstruction. It's a powerful tool.
Okay, so we've covered infection, trauma, radiation. Now we get to something that really emerged relatively recently, and it's kind of a medical paradox, a side effect from drugs meant to strengthen bone. Let's talk BRONJ. This really caught people by surprise, didn't it?
Absolutely. BRONJ, bisphosphonate-related osteonecrosis of the jaws, basically appeared as a new condition around 2001-2002. Clinicians started noticing patients, particularly those on intravenous bisphosphonates, for cancer reasons, developing areas of exposed, dead bone in their jaws, often after something like a tooth extraction, but sometimes just spontaneously. It looked like a really stubborn form of osteomyelitis. And the paradox, like you said, is huge. These drugs are revolutionary. They're incredibly beneficial for managing high calcium levels in cancer, treating bone metastases from things like breast or prostate cancer, Paget's disease of bone, and of course osteoporosis. They work by reducing bone breakdown, preventing fractures, reducing pain, massive quality of life improvements for millions, and yet this devastating side effect in the jaw.
So what's happening? How does a drug that stops bone loss cause bone death?
Well, that's the fascinating part. Bisphosphonates are very effective at inhibiting osteoclasts. Those are the cells that normally resorb or break down old bone as part of the natural remodeling process. They also seem to affect osteoblasts, the bone-building cells, and overall they significantly slow down that normal turnover of bone. Old bone isn't replaced as readily. More recently, we've also learned they can impair soft tissue healing, which is also crucial in the mouth. And here's another key thing. They bind strongly to bone and have an incredibly long half-life. We're talking years, potentially. So even after stopping the drug, the effect lingers in the skeleton for a long, long time.
And the diagnosis is quite specific to separate it from ORN, or regular osteomyelitis.
Yes, there's a clear case definition. You need three things. 1, current or previous treatment with a bisphosphonate. 2, exposed bone in the jaw that's persisted for more than 8 weeks. And 3, critically, no history of radiation therapy to the jaws. That last one rules out ORN. Risk-wise, it's definitely higher with the intravenous forms used mainly in cancer care compared to the oral forms used for osteoporosis, but it can happen with both.
Okay, so given how widely these drugs are used, preventing this must be a top priority. What's the key, according to the sources?
Prevention is absolutely the best strategy, and the ideal time is before the patient even starts taking the bisphosphonate, if possible. This requires real communication between the prescribing doctor and the patient's dentist. The goal is to get the mouth as healthy as possible first. That means extracting teeth that can't be saved, finishing any needed root canals or fillings, treating gum disease, and allowing time for healing, usually about 14 to 21 days before that first dose of bisphosphonate. This pre-therapy dental clearance is so important.
What about people already taking them, especially long-term for osteoporosis?
Yeah, that's a huge group. For patients on IV bisphosphonates, the advice is generally to maintain meticulous oral hygiene and avoid elective bony surgery if possible. Things like root canals are preferred over extractions. Dental implants are usually contraindicated. For patients on oral bisphosphonates, the risk is lower but increases the longer they take the drug, especially after about 3 years. For these patients, if they need significant dental surgery like extractions, and especially if they have other risk factors, the idea of a drug holiday comes up. The suggestion is often to stop the oral bisphosphonate for at least 3 months before the surgery, and maybe continue it for a few months after, allowing time for healing. But again, this has to be a conversation between the dentist and the prescribing doctor, weighing the fracture risk versus the BRONJ risk. It's not a simple decision. And informed consent, making sure the patient understands the BRONJ risk, is crucial before any procedure.
So despite best efforts, if BRONJ does develop, how is it managed?
When it happens, treatment is usually guided by clinical staging, developed by the AOMS, the American Association of Oral and Maxillofacial Surgeons. It ranges from stage 0, which is like preclinical signs, up to stage 3, which is extensive disease. Stage 1, maybe just exposed bone but no infection, might be managed conservatively with things like antimicrobial mouth rinses and close monitoring. Stage 2 involves pain and signs of infection, so antibiotics are added. Remember, BRONJ itself isn't primarily an infection, but the exposed dead bone easily gets secondarily infected. Stage 3 involves more extensive bone exposure, maybe fractures or fistulas. This often requires surgical intervention debridement to remove the dead bone, sometimes even resection of a part of the jaw. And regardless of stage, if there are loose pieces of dead bone, sequestra, those are generally removed carefully to help relieve irritation and potentially allow soft tissue closure. The drug holiday during treatment is, well, it's debated. Stopping 5E drugs probably doesn't help much in the short term because they linger so long. For oral drugs, some evidence suggests that stopping them long term might allow for some slow, gradual improvement or better surgical outcomes. But it's not definitive and has to be weighed against the reason they were taking the drug in the first place.
Wow. And this whole BRONJ issue has had wider ripples, hasn't it? Our sources mention another unexpected complication linked to long-term bisphosphonate use, leading to a big rethink.
Yes, this is a really significant development. In recent years, there's been the discovery of these things called atypical femur fractures. These are unusual fractures occurring in the shaft of the long bones, most commonly the femur, the thigh bone, in patients who have been on long-term oral bisphosphonates, usually for osteoporosis, sometimes after just a couple of years, but often after 5 years or more. They can happen with minimal or no trauma, and patients often report thigh or groin pain for weeks or months beforehand. This finding has definitely led to intense scrutiny and a reevaluation of how long patients, especially those with lower fracture risk, should stay on these drugs continuously. The idea of planned drug holidays, even for osteoporosis, is much more widely discussed now than it was, say, 10 years ago.
So wrapping this up, we've journeyed from osteomyelitis, driven by infection and vulnerability, to ORN, the ghost of radiation damage, and finally BRONJ, this unexpected consequence of medication. They're all clearly major
They
challenges.
really are. As the sources emphasize, these are all potentially very difficult clinical scenarios to manage. Patients often face long, complex treatments, multiple surgeries, sometimes, frankly, disfiguring procedures.
Hmm.
And it really brings it home that something seemingly as routine as common as getting a tooth pulled can, under the wrong circumstances, whether it's underlying health issues, radiation history, or medication use, trigger these incredibly serious, life-altering problems.
Absolutely. It shows that even with all our medical progress, we don't have all the answers yet for preventing or perfectly managing these conditions. Clinicians need to be constantly vigilant. Research is ongoing. It just makes you appreciate the complexity, doesn't it? How interconnected everything is: systemic health, local factors, treatments for other conditions, all converging on the health of the jaw. Well, that brings us to the end of this deep dive. Thanks for joining us as we explore these really complex jawbone conditions. Maybe next time you hear about a new drug or even a standard treatment, take a moment to think about those hidden layers, those unexpected connections. As we learn more about the body, what other simple interactions might turn out to have a much deeper, more complicated story? Keep thinking, keep questioning.